So with that, we'll go for the next presentation. I invite Dr. Kapil Parsa to share his screen, and he will talk on tips and tricks for management of reverse oblique fracture. Dr. Mittal, thank you very much, and I wish you will take active participation. Your inputs will be very helpful for this whole part of the discussion. We have more questions in the panel, but we'll take questions in between the talks. Otherwise, we'll stop at the discussions only. Thank you very much.
So I would request Samarth sir to kindly reply at the chat. There are some interesting questions there.
Yeah, in the meantime, you can
I'll
reply,
do
sir.
that.
That will help others. Yeah. Power, sir, please start. You are mute, sir. Kapil, sir, please unmute yourself. Yeah, fine.
Good morning, everyone. Can you hear me now?
Yes, sir, you can hear.
Yeah. Thank you, Dr. Bishnu, Dr. Gunjan, for calling me on this good platform. Uh, it was wonderful lecture by Dr. Samarth. I think most of the tips and tricks he has already covered, but let's go through the difficult variety, which is difficult one, a reverse oblique one. Let's do justice to it. So we'll be going through a presentation of a reverse oblique fracture IT tips and tricks to reduce it. We will be going through introduction, little biomechanics about it, planning about it, which implant to select, how to get a reduction, and how to apply the implant properly, the complication and managing them well. So I don't know why this. So is the slide changing there? Hello?
Changing, sir. Changing.
Okay. So the reverse oblique was first described way back in 1946 by Harlem Hospital, New York, by Dr. Wright. So he has observed a pattern that it happens in a indirect trauma by a patient walking in a hyperextension sort of a injury with a weak musculature, ligamentous, and a little osteoporotic bone. So that was the first description they have came up, and it is thought to be called as an oblique subcervical because it starts in the Y ligament of in between the two part of the Y ligament, and then it extend uh, laterally and distally from the proximal medial side. As we said in OTA and AO classification, as Dr. Deepak told, it is already classified into A3, and one being lateral, distal, medial, proximal, two being transverse, and three being multifragmentary. They are basically an unstable fracture where the lateral wall continuity is lost, and that makes them special. Uh, Main challenges are it basically behaves like a subtrochanteric fracture, where you will find that the proximal fragment will go more in flexion, more in abduction and external rotation, the way it happens in a subtroch fracture. The distal fragment will be adducted, and because of the iliopsoas, it will get medially pulled and proximally migrated with a sag. So this fracture has a lot of varus and shear forces compared to IT. If you take about 100 kg patient, then basically 4 times the body weight is a tension on the outer side and 6 times is the body weight is in the compression. So they are biomechanically quite large forces acting across this. As Dr. Summers said, the 2009 paper, the Dan Berry group or Dr. Haiduk, which published first in 2001, that this variety has a problem with a standard DHS. So the DHS, when it is done, and since there is a lateral wall fracture and the lateral buttress is not there, so there is no resistance and it just slides out with the shear force, and there is a medialization of the shaft. This DHS failed in the reverse oblique very badly, and it was noted by many authors. And basically, the failures are of two types. Basically, it was a implant failure where the radiologically it is seen that it is cut out superiorly, medially, or there was implant failure by loosening or breakage of an implant. Clinically, there are some fractures of reverse oblique with that DHS also they united, but they united with a massive medial shift of the shaft up to 1.5 centimeter is the shaft going medially, and it slides medially till the time it stops there by the neck and head junction, and then the patient unites with a lot of varus shortenings, giving them abductor lunge and the functional disability sort of. So what is important in this fracture is we have to avoid medialization of that distal fragment at any cost, because once we medialize it, there is a reduced bone contact. The forces, biomechanical forces are going more abnormal, which lead to implant failure and fixation failure. So there is this paper by Acta Orthopedica long back which tells that the percentage of medialization is equivalent to percentage of failure of fixation, where you can see that the medial translation divided by the total width into 100 is basically amount to the failure fixation. So when we talk about it, as rightly mentioned by Dr. Samarth, that it's just not a pre-operative classification on the X-ray that it says a reverse oblique. More of the patients can get it intraoperative or some get in post-operative, mainly in the osteoporotic patients, where we find that, as mentioned by Dr. Deepak, the lateral wall thickness is less than 20 mm. There is a chance that intraoperatively or post-operatively there can be a lateral wall blowout, and which can give again it to the variety of subtrochanteric, this reverse oblique type of fracture, which is unstable one. So this paper shows that in a 81 and above year age, there's a chance of 6 of out of 9 fractures going into the iatrogenic lateral wall blowout, and 3 out of 9 fracture going into the post-operative blowout. So that can convert a fracture which was not initially a reverse oblique, but then later on goes to the reverse oblique. So considering that, we need to plan it on the X-rays. The X-ray, we need a AP and lateral radiograph. What we want to see is basically a reverse oblique, which is extending into the trochanteric area, as we say, because the trochanteric area is important for putting a nail, and any comminution or the fractures there can make us a choice between the implant difficult. We need to have a full length X-ray of a femur, because we need to rule out the any escape lesion. If it is osteoporotic or pathological, we need to see the femoral bow, and we need to the width of a long nail if you want to take a long nail. We want to see the contralateral femur also to know the normal neck femur angle. As said by everyone, and that windshield wiper effect, basically what we think the proximal femur is not that as strong as we think. There are some trabecules and this calcar, vertical, horizontal, but if you take it in a histopath model, there are a lot of empty lacunas or areas where there is not a good hold. So above LT and below LT, there are two different type of holds. And so this fracture is basically below LT, you will get a hold by the nail, but the above LT, we will have to see what things best fits. Sometimes in the cases where there is a osteoporosis, you would like to change the implant. So what are the implants? Generally, we can think about the reverse oblique is basically there's dynamic hip screw, which was traditionally done with a lot of problems, what we discuss. You can put a DCS, which can avoid a little medialization, but it still give little medialization. Locking plate, they are not biomechanically that strong. There's something called a trochanteric stabilization plate, which can take out the problem with the DHS by buttressing the lateral wall. Angle blade plate. This is now reintroduced again with a locking sort of screws also. Intramedullary, you can go in a construct of a PFN type of a nail with either blade or a screw, recon type of nail, or like a intertan nail. So we'll come to it one by one. So DHS, as it was introduced in 1934, fracture was described in 1946, and the first paper by Barry or Dan Barry group, what we know in Orthoplastivel or Hydokvich et al. They showed a 56% of a failures by DHS, and the main way of failing is medial shaft displacement or a cutout or an implant failure. So it's not a great choice. There was a biomechanical study made by Curtis in 1994, which showed that the DCS works far better than the 135 degree implant, but intramedullary nail is far stronger implant compared to the DCS as well. So that's how we again come to a Dan Berry's second paper, where he has already said that the fixed 95 degree angle are done better than that, and these are the choice of implant at 2001. But then later on with the nails have shown a persistently better results compared to DCS as well. Plates, when we come to the plates, they offer us a buttressing effect, multiple screws, but running down to the biomechanical stresses at that site, there's a lot of stress and the plate just break off, or they can have a screw back out, and there are 41% complication recorded. But this is still a good method of fixation if you're getting a very young patient, I would say 15, pediatric age group or early adolescence, where you will have a problem with any other problem. The trochanteric stabilization plate is basically a plate which can put on the DHS plate, where you can stabilize the lateral wall by an extended plate. And this has shown that the medial displacement is significantly reduced, but in a long course of time, there's still a lot of complication with that plate, and there's a failure noted. So it's not quite good modality, I would say. Coming to the DCS or dynamic condyle screw 95-degree versus nail, literature do show that radiological parameter wise, they are both equal. But if we consider the opening, the blood loss, and the simple technique of a nail, I think post-op scores and the intra-op complications are far less in a nail group. So once we say about a reverse oblique, and basically it's unstable fracture, and as told by Dr. Samat, I agree that the nail becomes a first choice. So why nail? Because they are load sharing implant, they are intramedullary implant, the shorter moment arm from the load bearing side, and they prevent both sliding and rotational instability. So this medial displacement is stopped many times just by the size of a nail. So because of this thick proximal portion of a nail, the neck and head fragment cannot slide beyond a certain extent, and the screw has a less excursion. So this, in a short nutshell, a biomechanical study which shows that DHS got an infinite instability. You can see the medialization going up to 1.5 centimeter. DCS is better, but it still will have some slide and some rotational instability, while nail will not give you much of a slide, and it will give a rotational stability as well. The only problem with the nails is nails work best when they are in a content proximal femur. If there is a posterior wall blowout, then there are chances that if you put a nail into it, it will just slip off and it will give a cutout. So these are the cases where the surface fixation may think of that. Now coming to the nails, you can opt any kind of nail like recon nail, PFN screws, blades, intertan, depending upon your expertise, your choice, and fracture. So the nails, in 1940s, this Kuncher fellow from Germany, he told, put a nail inside and keep everything like that and it will heal. So basically he came with a nail which is going into the femur, and one short nail going into the uh, head and the neck. Later on, the reconstruction nail with a two screws came, then gamma nail with a single screw, then 2000 where we got a PFN blade, and 2004 intertan where we avoid a collapse of a head by locking both the bolts here. Coming to execution of a tips and trips to execute this reverse oblique fracture better with a nails, you can have all three positions. Either you can have a supine on traction table as discussed and favored by Dr. Samat, or you can have a traction table with a lateral position if you have that, or you can have a simple lateral position. In doing a nail in a reverse oblique in a basically supine position, there will be a lot of adduction, flexion, which will be required compared to the normal IT. So it becomes a little tricky and little difficult. Lateral position, the hip flexion and the adduction becomes very easy. Getting the entry point is easy. So this is a favored position that works better. But the lateral fracture tables are pretty rare. So even if you do it in a normal lateral position, it helps you. Basically, you have to put a pillow or some cushion between the two limbs, which automatically takes out that, as you can see in the lower figure, the distal fragment will get lateralized and the reduction is little easy. The only problem in this is you have to get accustomed to see the lateral view in a C arm, because sometimes you get an overlap between this hip and the contralateral hip. Open reduction is always an option if you can't get a good reduction. But as discussed by Dr. Samat, we have some techniques and tips and tricks which we can use for reverse oblique. So getting an entry point in the nail is very crucial in the both view, like anterior-posterior or medial-lateral. Getting it lateral and in a very varus fracture will keep that varus like that. So you have to take the entry just medial to the tip. Then only you will able to reduce it. Getting it very anterior can get a blowout, or getting it posterior also can be a problem. The hip is quite a flex, so getting it in the center is important. At the same time, getting that entry in the center and reaming in little lateral direction and little anterior direction can get you the reduction. So trajectory of the reamer is also important. See, never accept a varus reduction, and we can have some tips and tricks. The only putting wires in a varus will not avoid the failure of an implant, as you can see. Putting it in the varus, how you can know if you're going a little longer screw. If you see that the screw is in the superior aspect in the head, but in the inferior middle aspect in the neck, the beak in the canal, these are some signs that you're probably going in the varus. And how to avoid it? These are some methods. So there are external method and there are some internal methods. So external method, you can ideally give a manual compression by using the mallet handle or reamer handle. There is something called as a F tool, which you can use it without actually going through the wound. But these have their own limitations. Best is to use the spikes, ball spikes, Homan retractors, or hooks through the incision, as already told. So basically, a ball spike is a good instrument which can push the lateral wall or anterior wall down. The Homan's retractor are used through the blade side, where we can take the flexion, neutralize the flexion. And sometimes there are a lot of rotations, and there was a question how to neutralize that rotation. So a joystick maneuver with a shank pin or a thick pin, and you can rotate the externally rotated fragment, do help. So as we can see here, the ballpoint spike can give that anterior fragment. You can compress it down. The joystick maneuver helps basically to rotation, and the Homans are used for pushing. And with all of this, you can get the reduction either with a hook to lateralize basically the shaft, the Homans to press the lateral fragment, the pin to rotate, derotate it, and you achieve both flexion, rotation. Whereas once you are done that and you think it is unstable, there's no harm in putting a wire after a well-reduced fracture and then start putting a nail. Another technique where basically in type 2, which acts like a transverse fracture, you can ideally have a bone clamp through the wound, and then you can do all the things like you can get it into extension, get it into valgus, and you can reduce the rotation also, and then you can pass the wire. This is just an example. So once you see a reverse oblique and you get a reduction with the clamp, you pass a wire, and then because of this posterior middle combination, even the lateral X-ray shows that the wire is going good. It starts collapsing into the varus. So what you can do is, even after you have done it, you can get a temporary wire and hold it in the valgus, so that while passing the reamer, it stays in a valgus. So if you pass that reamer in that line, the final nail will go into the line of a reamer, and the valgus will be maintained. Regarding the lag screw, it's not like 10. You can have a TAD of 25 millimeters. Blades are better in the osteoporotic bones. Regarding the nail, I would say that these are unstable. Reverse oblique, basically, it's good to use a long nail. I prefer the long nail. Regarding the distal locking, it's better to use a static mode, because still there with a nail, there will be some amount of shear forces and sliding there. And the complication to avoid is basically cut out. If you do a proper reduction and then put an implant, then maintain a good TID, the cutout will not be there. You have to avoid varus at any cost to avoid non-linear implant failure. So basically, going back into the problem, the implant failure can happen if there is not a good reduction. If it is in the varus, if it is a distraction, even the nails will fail. And that has been highlighted quite a much. As you can see in this X-ray, it was in varus, it was in distraction, the nail failed. Blade plate is a very stiff implant, and as we talked about, there are a lot of stresses, and the head fragment, if it is already in a revision cases where you don't have a bone stock, you can think of using an angle blade plate, where you can go in the inferior and posterior sort of quadrant, where you can get a bone, where you can get a good fixation. Again, with a cutout, revision can be a place with the blade plate. So blade plate also has a role, basically in the revision and when there is a bone stock problem. So in summary, the reverse oblique fractures are basically unstable fracture. They behave more like a subtroch, and intramedullary nails is a good choice. Always achieve a reduction first by whatever trick and then put an implant. Correct entry point and correct trimming is important. Avoid virus and distraction at any cost. Thank you.
Thank you, Kapil sir. It's really a difficult topic because every surgeon might have faced difficulties in handling such fractures. Many times they feel it's really a simple fracture, but they will do in just few couple of minutes. But on table, they find really a tough job for them to handle it. So thank you very much for this input. But still, there are a lot of things we need to learn on this particular reverse oblique, because even in the best of the best hands, we have seen complications and non-unions, and this they are more likely subterranean fractures with poor vascularity and very tendency for non-union. Just to elaborate one of my case, I have operated a patient 3 times and that did not unite. And there was no deficit. I did nailing from very first time to third time, but all the 3 times the patient did not unite. So it's really still a challenges for us dealing these type of fractures, looking at the vascularity of the such particular bones, and later on with multiple grafting injections that united, but still I don't think the quality of bone that has been gained is really appropriate. So thank you very much. Any other questions from the panelists or the delegates? Please let us know. Any specific scenario where you would do this surgery in lateral position from Dr. Siv Kumar?
When I put a nail, basically I like to put it in a lateral position only because it helps me to control the proximal fragment quite nicely. I think I struggle quite a lot in a supine position on a fracture table. So that's my preferred position to do.
But is there any difficulty in getting the CM images when you go in?
Yeah, the CM images will always have a problem because the hip, which will be nearer to the receiving plate, will be smaller compared to that. So you will have to get adjusted to know that one hip you will look larger and one hip you will look smaller. So depending on that, and you can have a little oblique view to see which hip. But after some, I think a couple of cases, you get adapted to it that the larger one is this one, which is our hip, and the other one is a different one, which is smaller.
So there is one more question. Once he said that many times this blade plate falls on the fracture line in the
The
reverse
blade
oblique.
plate basically when there is a cutout scenario when the bone stock is very less, then the fixation per se in the posterior inferior quadrant, the blade plate achieves a very good solid fixation. So sometimes revising the nail, the blade plate gives a stable construct just because it gets the bone stock at the quadrant, which generally a nail can't go to that level. So the entry is little higher at trochanteric site and we are going and directing it to the posterior inferior quadrant. So there is the bone which is available to get a good hold.
Any other inputs from any other panelist?
Right. So I think one must be clear that reverse oblique fractures are not fractures in which you do a surface device, at least initially. They are de rigueur and nailable fracture. And to nail them, you need to get good reduction. You can get it in a large number of ways. I don't do any of my reverse obliques in lateral position. In fact, I don't do any lateral position at all. I just do supine position. And still you can get a very, very nice reduction if you follow certain principles, one, and two, make sure that you get a absolutely good quality reduction before you start before you start with your entry point. That is very
That's
important.
the key.
You cannot expect your nail to reduce your fracture. You reduce the fracture, the nail only holds the reduced fracture in position.
I think we can a couple of times we use some of the joysticks that will help for your.
Yes.
There one delegate has requested for the recording of these presentations. I will talk to Dr. Gunjar so that it get available to you, but
Yes.
I'm not aware of it. So thank you, sir. Kapil sir. We'll move on to the next discussion by Dr. Asad.